Great. Good morning, everyone. This is Lydia Chwastiak. I'd like to welcome everyone to our Northwest MHTTC webinar this morning. Thank you so much, everyone, for joining. On behalf of MHTTC, I'd like to welcome you to today's webinar. I am Dr. Lydia Chwastiak. I'm a psychiatrist and a professor in the Department of Psychiatry at the University of Washington. And I'm the co-director of the Northwest MHTTC, which is sponsoring this 60-minute webinar. We are very excited to bring this webinar to you today. This is very clinically relevant information, and we hope that this will influence treatment and practices on this very important topic of improving the provision of evidence-based care for nicotine dependence for people with serious mental illness who smoke. So just to remind everyone what the MHTTC is, the network is a national network that is supported by SAMHSA. And it aims to support the dissemination and implementation of evidence-based practices for mental health disorders. The network consists of a national coordinating office, which is in Stanford, California, 10 regional centers. So we're HHS Region 10 up here in the Northwest and Alaska, a tribal affairs center, a Hispanic and Latino center. So together, this collaborative network supports research development and dissemination, training and technical assistance, and workforce development for the behavioral health workforce throughout the country. This webinar and all of our services from the MHTTC are offered free to the public. The MHTTC is based, as I said, at the University of Washington in the Department of Psychiatry. We provide training and technical assistance in Region 10, which is Alaska, Idaho, Oregon, and Washington, to support effective practices for serious mental illness. And our target audience, which I think is demonstrated today, includes behavioral health, primary care providers, school and social service staff, any provider whose work has the potential to improve behavioral health outcomes for individuals with or at risk for serious mental illness. And our goals are to heighten awareness, knowledge, and skills of the workforce, addressing the needs of individuals with mental illness, to accelerate the adoption and implementation of mental health-related evidence-based practices across Region 10, and then to foster alliances among culturally diverse mental health providers, policymakers, family members, and clients. It's our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. So we encourage all clinicians to use and champion person-first language, which emphasizes the individual, not the condition or disability. Person-first language is a way to demonstrate respect for a person's dignity and worth, and it's consistent with recovery-oriented practices and promotes treatment environments that foster respect, human dignity, and hope. So before I introduce Dr. Evins, we'd like to take a moment just to find out who's joining us today. You should now see a poll up on your screen with several response options about your role in your organization. And so if you could just respond to the poll. Primary learners that we'd identified for this are psychiatric prescribers, nurses, and community mental health clinicians, but very interested in finding out who's attending today. So if you are in the other category, if your role is not listed, please check other and then type in into the chat box what the nature of your role is. Great, so here's some of the poll results. It looks like we have a nice distribution across the board, including some administrators, and then in our other category, it looks like a number of clinicians. So, so great. So thanks for sharing who you are, and again, welcome this morning. We're excited to have you. I'm excited to introduce today's speaker, who is Dr. Evins. She is an addiction psychiatrist and the Cox Family Professor of Psychiatry in the field of addiction medicine at Harvard Medical School. She is also the founder and the co-director of the Center for Addiction Medicine at Massachusetts General Hospital. She received her MD degree from the Medical University of South Carolina in Charleston and an MPH from Harvard School of Public Health. Dr. Evins's research has focused on the efficacy of pharmacotherapy for smoking cessation in smokers with and without serious mental illness and the effect of nicotine on cognitive performance. She's been honored by the National Institutes of Health for her work, and she has led several very large research studies that have changed clinical practice guidelines for tobacco smoking cessation, both for individuals with serious mental illness and also those without. And she's the principal investigator of a current multi-site study in 6 states in the US and also a large PCORI-funded Pragmatic Trial, which has enrolled over 1,100 tobacco smokers in the greater Boston area. So we're delighted to hear from Dr. Evins this morning, and I will turn the presentation over to her.
Thank you, Lydia, and thank you all for being here. It's a pleasure to talk with you out in the Pacific Northwest. I'm here in Boston on a sunny, cold day, and I'm delighted to be here. I really am here with good news, which is fantastic position to be in. There are tools now to help our patients with and without serious mental illness to quit smoking. Meds that work and are well tolerated. So varenicline does not increase adverse events is essentially the headline of the news today. So these are data from the Eagles trial, which was the largest trial ever done to test smoking cessation treatments. This was in 8,000 people worldwide, 4,000 with and 4,000 without a mental illness. This trial had about 2,400 people with major depressive disorder or bipolar disorder, over 700 people with a major anxiety disorder, and 400 people with a schizophrenia spectrum disorder. So these first bars show the percentage of people who were in the non-psychiatric cohort, so people without an Axis 1 disorder that they reported on a SCID, who had an adverse event of a neuropsychiatric nature during 12 weeks of treatment and 4 weeks of follow-up with either varenicline, which is the first bar, bupropion, which is in green, 2.2%, nicotine patch, 2.5%, and placebo, 2.4%. So you see that in those who received placebo, they had nearly the same amount of adverse events during a smoking cessation attempt as those who were on a medication. In the psychotic disorders cohort, you can see that more patients had a neuropsychiatric adverse event during treatment and follow-up. This was a significant difference, that people with a schizophrenia spectrum disorder had more incidence of neuropsychiatric adverse events when they tried to quit smoking. What's interesting, and I don't think you can see my cursor, unfortunately, is that there's no difference in the rate in those who were treated with varenicline, 6.3%, and those who were treated with bupropion, literally the same, 6.3%, and those who were treated with placebo, 6.3%. It's slightly lower, although not statistically significantly different. 5.1% of those on NRT, nicotine patch, had a moderate to severe neuropsychiatric adverse event during smoking cessation treatment. So there's a significant difference between the non-psychiatric and the psychiatric cohort, almost threefold more likely to experience a neuropsychiatric adverse event. Most were transient, very few required discontinuation of treatment. And you see the same situation in mood disorders. These are not statistically significantly different. You've got 6.8 and 6.4% of those with mood disorders who had an AE on varenicline and bupropion respectively, and 5.6 and 4.6 on NRT and placebo. But again, those differences weren't significant. These are safety data that were required by the FDA, and the study is an unusual study. It was literally powered to estimate the incidence of neuropsychiatric adverse events during a smoking cessation attempt. And as a clinician, I find that super helpful because I can actually counsel patients that if you've got a serious mental illness and you want to try to quit smoking, you've got about a 5 to 7% chance of having some perturbation in your psychiatric symptoms during the 4 months that are coming, 3 months on treatment and 1 month off of treatment if you're following this treatment schedule. If you don't have a serious mental illness, you've got about a 2% chance of a neuropsychiatric adverse event. And what's really important, and I was a lead author on this study, and we really scoured the data to find that we didn't find any patterns of neuropsychiatric adverse event in really the most worrisome categories, right? So suicidality, irritability, hostility. We did not find a pattern. They were really quite sporadic. And we have not identified a psychiatric subgroup that are particularly increased risk. We've now published papers, and our schizophrenia paper will be out soon. It just was accepted. But we've published papers in the bipolar disorder subgroup, that's out, in the anxiety disorder subgroup, that's out, and then the psychotic disorder subgroup is coming out. So while there was no difference in across treatments in neuropsychiatric adverse events, you can see here that there's a clear difference in terms of efficacy. So to the far left, this is the non-psychiatric cohort, about clearly superior. Varenicline is better than bupropion or nicotine patch, and all three are better than placebo. Now that follows on study after study. There's never been a head-to-head comparison across these four different treatment options. The fourth being placebo plus behavioral treatment alone. But this does follow what we've seen, where there are three effective medicines, NRT, nicotine replacement therapy, bupropion, and varenicline, but varenicline is consistently superior to the other two, roughly tripling your odds of quitting, whereas bupropion and NRT increase your odds of quitting by about 80%. Now, if you look at the middle cluster of bars, this is the psychotic disorders subgroup, and it's the same pattern. And so varenicline is superior to NRT and bupropion, and all three are superior to placebo. But what you see here, I want to take a second, is a 4% chance of quitting with behavioral treatment alone amongst the psychotic disorders subgroup. This is a number that we see over and over again. In fact, if you tally up the data in the Cochrane review of smoking cessation and schizophrenia, what you will find is a 4% quit rate in the placebo arms of all the different studies that have been done. So people with psychotic disorders are very unlikely to quit without a medicine, but yet they're the group who are the least likely to get treated with a medicine to help them quit smoking. So they need it the most, literally, and they're the least likely to get it. And in the paper we have coming out in Psychiatric Services, we really point to two places where this is a problem. They're less likely to be prescribed the medication, and then there are also significant barriers, both in terms of cost and accessibility through Medicaid and Medicare, for which most of these folks receive their health benefits. So we aren't prescribing them enough, and there also can be major sort of prior authorization barriers and cost barriers. So on the mood disorders group, you see the same pattern. Varenicline superior to bupropion and NRT, and all three superior to placebo. So on efficacy, the comparative efficacy data were based on the Eagles trial, which was published in the Lancet. And it really is it's considered sort of a confirmatory finding because it echoes so many prior trials. And it was based on these data that the European Medicines Association immediately removed boxed warnings on varenicline and bupropion. And the FDA took about 9 months, but eventually they also removed boxed warnings, and it was based on these data. So there's a little quiz here, just to that I think you'll see now. A couple of questions. The first one: it only makes sense to prescribe a medication for smoking cessation in smokers who say they're ready to quit smoking right now. Is that true or false? Myth or fact? So number one, people with serious mental illness don't want to quit smoking. Now, if you are working in this area and you ever ask, you'll see that that's really not true. Yeah, 60 to 70% of people with serious mental illness who smoke say they want to quit. And that's on par with general population smokers. They aren't always ready to quit now, and they're certainly not confident that they can quit smoking, but they do want to quit smoking. And so holding those two in mind is really helpful. Their confidence is low. They know it's going to be hard. Many have tried several times to quit. And as in our Eagles trial, the people with psychotic disorders were significantly less likely to have received any medication to help them quit smoking, even though they did not have fewer prior trials, cessation attempts. So quitting worsens psychiatric symptoms. Now, really, you guys didn't fall for that one? That's amazing to me, because early in abstinence, nicotine withdrawal symptoms can look like worsening of psychiatric symptoms, because you get some depressed mood, some negative affect, some sleep disturbance that you need to let patients know about. But those really peak within about 4 days, and they're gone in about 2 weeks. And in the end, stopping smoking actually improves depressive symptoms as well as anxiety and stress, with an effect size equivalent to an effective antidepressant medication. There's a paper in the reference list that you'll get at the end that shows this. It's a very nice meta-analysis. So myth, medications don't help people with SMI stop smoking. Now, I would think that people believe that because we are prescribing for people with SMI. But in fact, smokers with SMI are 3 to 6-fold more likely to quit when prescribed a medication, and only about 4% quit without a medication. And I don't know if you liked this, to look at things in terms of number needed to treat, but essentially the odds of quitting, while the absolute quit rate is lower in those with SMI than general population smokers, the odds of quitting with a medicine are higher. And the number needed to treat with, with varenicline to get one person to quit smoking is the same in those with and without schizophrenia spectrum illness. So the number is 4.5. So by the 5th person you treat, you should have one more who would quit that wouldn't have quit without a medicine. I hope that makes sense. It's hard not to be able to see my audience. So medication should only be prescribed for smokers ready to quit. And again, I'm surprised everybody really got that answer right. The new prescribing guidelines that I'll go through actually recommend a medication, physician recommendation that you quit, or physician, nurse, whatever provider you are, recommend that all smokers quit and offer a medication. So actually say, I'd like to prescribe a medication for you today. And if they say, oh no, doctor, I'm not ready to quit today, you say, well, please start this medicine and we'll talk in a month, because taking this medicine for a month may change your assessment of how ready you are to quit, right? So that's really a paradigm switch. And the FDA has put out 3 different ways to quit, including this flexible quit and gradual quit. 3 ways to quit smoking, and they all start with a medication. So the first one, fixed quit, is what we're used to. You start a medication and they set a quit date 1 week later, and you prescribe the medicine for 12 to 24 weeks, and it all goes great. I never do it this way. I always use this middle method. In all my studies going back 15 years, I start a medication and I ask people to set a quit date in 4 to 5 weeks. So usually between the 4th and 5th week, and it's often the night before the visit on the 5th week, I ask them to quit smoking. That's now codified. That's called the flexible quit. You start a smoking cessation medication, and you sort of pick a quit date within 1 to 5 weeks, and you can keep smoking during that time. So you take the medicine and you're still smoking. And I ask people not to change their smoking behavior. I tell them, you've been smoking for, usually it's 25 years. So another 3 weeks isn't gonna change anything. And in fact, one reason I think this has worked for in my studies and in my practice is that people take the medicine for a month. So we all know that whether or not they're tolerating the medicine, long before we introduce sort of nicotine withdrawal symptoms into the equation. And it's really not that rare that I'll have people, they start varenicline and almost everybody gets a little nausea. Some people get some vivid dreams, sort of technicolor dreams. But by and large, they tolerate it. Very few people have to stop the medicine. But lo and behold, in the 4th week, I will start to have some people with a new headache, with various complaints, which really are a combination, in my opinion, of some ambivalence about quitting and some nicotine withdrawal symptoms. But it just changes my confidence level hugely if I know that they've tolerated the medicine for a month before their quit date. And then lastly, there's the gradual quit. And these are for people who are saying, no, like I'm just not ready to quit anytime soon. And so I'll start the medicine and we'll say, okay, we're going to just try to reduce. And in the first month, we're going to try to back down by 50%. So you go from 20 cigarettes a day to 10, just a little by little over 4 weeks. And then in the next month, you try to go down by 50% again. So that gets them out to 8 weeks, and maybe they're down to 5 cigarettes a day, right? And then you continue reducing, and hopefully by 12 weeks, by 3 months, you've reduced down to almost nothing. And in that case, you would try to go to, get them to go to 0 at that point, and then you continue the medicine for another 12 weeks. So everybody gets 24 weeks of treatment. And in fact, across all 3 of these, 24 weeks of treatment is recommended. And in most cases, it's available with or without 1 prior authorization at 12 weeks. So what do we do to address smoking? So in your visit, you assess, you engage, you prescribe, and you follow through. So at every clinic visit, you ask them, are you a smoker, right? Do you currently smoke tobacco? At every visit for any smoker, you say to them, in my opinion, or in fact, we know that quitting smoking is the #1 best thing you can do to improve your health. And as your treater or somebody who cares about you, I recommend that you start a treatment to help you quit, and let them know that using a medication can increase not only their success in quitting, it can increase their readiness to quit. Okay. And then for every smoker at every visit, you offer to and recommend that they take start a medication to quit. And really, I end up in a sort of a sales position. I really have to say, I really need to recommend that you get the best treatment that you deserve. And the best treatment is for you to start a medication and to work with someone to help you quit, whether that's a nurse in the office, with me, with the quit line, with a smoking cessation group that's outside. And I encourage them to take a prescription for varenicline is my first choice. Dual NRT is my second choice, which is also very, very good. It may be as good as varenicline. And then second line treatment is single NRT or bupropion. And then I schedule a follow-up anytime within the first week to month. I really try to see somebody within a week of starting varenicline so that I can hear if there are any problems and fix them if there are, a dose change, whatever. Remind patients that most adverse events are mild and transient, and most people have something. So, you saw 6% had a moderate to severe neuropsychiatric adverse event in the first slide. Well, 30% had some AE, mostly were mild in the psychotic disorders group, and over 40% in the general population group had some side effect in the first over 12 weeks of treatment. So what I do in my first week is I problem solve around any missed medication doses or any tolerability issues, and I really reinforce persistence with taking medications. And I guess here it's something to remind you is most smokers require repeat attempts to quit. The average smoker tries 5 times before they quit for good. And so I love to say that to patients. Often I'm teaching them how to use nicotine gum or something because they haven't used it correctly in the past. And they'll often say, I can't do this, doc. I've tried to quit and I failed. And I'll say, well, how many times? And they'll say, usually 3 is the average. So three times I've tried to quit. And I say, well, that's not even average for a successful quit. Most people who are successful take 5 tries. Okay, so how to? So for those with serious mental illness, it's the same as those without. Varenicline titration is quite easy. It's 0.5 milligram a day for 3 days, and then 0.5 milligram twice a day for 4 days, and then 1 milligram twice a day for 11 weeks. Now, an additional 3 to 9 months of treatment is recommended in those who achieve abstinence, and I'll show you those data in a bit. So it's renally excreted. So it's really nice in terms of it doesn't interfere with other psychiatric medications that people might be on. It doesn't impact cytochrome enzymes. And I've used it, in people with varying degrees of renal impairment, right down to dialysis. They can use a lot less medicine. They just get dosed right after their dialysis. And if somebody's got severely impaired renal function, I'll treat it in consultation with a nephrologist. So nausea is the most common. I say 60 to 80% of people get some nausea. It's usually mild. It's improved by taking the medicine with a full big 16-ounce glass of water, and so food. Headache's quite common. It's usually pretty mild. Insomnia and vivid dreams are common. And just to let you know, I've almost never heard of nightmares. It's vivid dreams, technicolor dreams, and boy, we'd hear about them in group. People would like to tell about their vivid dreams, but it's really not nightmare. And the nightmares that's really important for the for those with trauma histories, PTSD, that we don't see nightmares. Okay, so NRT, I wish I could ask, do most of you use two forms of NRT when you use it? What I recommend is, and this is really standard now, is that everybody gets a long-acting form of NRT, which is nicotine patch. And I dose it almost in terms of like how many cigarettes a day. If they smoke a pack a day or more, that's 20 cigarettes or more a day, they get a 21 milligram patch. If they smoke a half a pack a day, that's 10 cigarettes a day, I give them 14 milligram patch, so it's corresponding. And if they smoke less than half a pack a day, I'll start with a 7 milligram patch. For people with very low income, it's good to know that the 21, 14, and 7 milligram patches are generally the same size. So people can buy 21, I mean, they're the same cost, so per patch. So I'll often, if somebody smokes a little less than a pack a day, I'll tell them to buy the 21 milligram patch and cut them in half. So that gives them half price patches. I use that in combination with nicotine gum or lozenge, any form of short-term NRT, which is very, very useful in a concrete way for people who may want to, instead of smoking a cigarette, they take a gum or a piece of gum or a lozenge instead, and they're able to that way titrate their dose. Bupropion, very simple, 150 milligrams a day times 3 days, and then 150 milligrams BID. Insomnia and sort of activation are the biggest problems with bupropion. So I don't tend to reach for bupropion first, particularly in people with anxiety. So how long should we treat? Nice. All right. I'm seeing the results here. So I'll start on the right-hand part of the slide first, since that was the first question. So really wonderfully, we have a study of varenicline in which, in order to be enrolled, you had to have tried varenicline in the past and be a smoker. So it's a quote-unquote failed attempt to quit. So either you quit and you relapsed or you didn't quit. And in this trial, the blue bar is the abstinence rate in those who got randomized to varenicline. So they previously failed varenicline, and there's a 45% abstinence rate. And in the gray bar is those who got randomized in this trial to placebo, who had a 10% abstinence rate. So that's right. You know, it takes on average 5 quit attempts, and it seems that we don't need to consider a medication quote unquote ineffective, like we might for, say, an antidepressant or even an antipsychotic, right? That doesn't seem to be the case for smoking cessation treatments. Now, on the left-hand side of this slide is a time course. Essentially, the numbers at the bottom are weeks, and this is abstinence rates from the end of a 12-week study. Everybody was abstinent. These are people with schizophrenia and bipolar disorder, schizophrenia, schizoaffective, or bipolar disorder. And at 12 weeks, they were all abstinent, so that's 100%. And at that 12-week mark, they were randomized to either stay on varenicline, which had helped them become abstinent, or go on placebo, but continue behavioral treatment. So they kept coming to groups every 2 weeks for a month, and then every month for a whole year. And what you see is what we see in clinical practice, which is a very fast relapse rate in patients with schizophrenia and SMI after stopping their smoking cessation medication. Now, we can have a long talk about why that may be. It may have to do with nicotinic receptors in brain, but what we see, the practical message here is that the median time to relapse in those who stayed on varenicline for a year was 358 days. And the median time to relapse in those who were absent at 12 weeks but went on placebo at 12 weeks was 35 days. So 35 days versus 358 days. And you can see the abstinence rates at 52 weeks were 3 times higher. So 19% in those who were abstinent initially at 12 weeks and went on placebo, and 60% in those who stayed on varenicline for a year. And based on these data, Paul Jeffries, who manages the MassHealth, the Medicaid pharmacy benefit in Massachusetts, made 52 weeks of varenicline available to all people with serious mental illness with a prior authorization at 6 months. So it's available in Massachusetts. I don't know about where you practice. So I think folks know this. This is a public health crisis. 64% roughly of people with schizophrenia smoke. So that's over 5-fold higher than the general population. Those with bipolar disorder is 3-fold higher. And this contributes to essentially a 29-year mortality gap in schizophrenia. It's a 25-year mortality gap in those with the general population. It's largely due to cardiovascular mortality. And so the mortality rate is 3.7-fold higher. So people are, living really literally a generation shorter. Next slide. And so we have opportunities to save lives. So every quit attempt, every time you help somebody try to quit, it increases their chances of being quit long-term in the future. It might not be that attempt, it might be the next turn or the next one, but every time you encourage somebody to quit, you may help to reduce this mortality gap. Because if you quit smoking by middle age, so 35 to 45 is what's generally, then you nearly abrogate this mortality gap. So this is the last main point I want to make today. The new treatment guidelines from the American College of Cardiology are out, and they encourage an opt-out approach. Right. So essentially what I was saying, they are recommending now that every smoker be offered treatment for smoking cessation, every single one. And then the decision tree goes from there, whether they accept or they decline. But it's not contingent on quote unquote readiness to quit or stage of change. That is essentially out the window. I mean, it's useful in behavioral treatment, but not in our care. And I kind of liken that to, if I'm managing somebody with type 2 diabetes or hypertension, I don't say to them, are you ready to reduce the salt in your diet and start exercising? And once you've started doing that, I will prescribe for you some metformin for your diabetes, or I will prescribe for you, an antihypertensive medication. No, I do both at the same time. I prescribe the medication and I recommend the behavioral change. So this is the new guidelines for American College of Cardiology for all smokers, not just smokers with serious mental illness. First line is varenicline or combination nicotine replacement therapy. And second line is bupropion or a single form of NRT. There are single studies showing that varenicline plus NRT is better than varenicline alone, and that varenicline plus bupropion is better than varenicline alone. And so there are data to support those. Until there are at least 2 studies, they won't make it into the sort of, first or second line recommended treatment. While I'm waiting to see some questions, I see 2 here. One says varenicline doesn't increase AEs in adults. Is that true with youth, including transitional age youth? That's a great question. And there are 2 nice studies out. One that's only published in clinicaltrials.gov because it's a report to the FDA. And the other is a study by my friend Kevin Gray down at Medical University of South Carolina, where I went to medical school. And they both show that kids aged 12 to 17 do quite well with varenicline. There's no tolerability issues. There are often adherence issues. So if and the efficacy is actually seems to be better in the younger kids than the older kids. And I wondered if that is we haven't seen the data yet, but that may be largely dependent on sort of adherence. Right, so the younger kids were more adherent to the meds, but and had better abstinence rates.
Great. Well, thanks, Dr. Evans. And I wanted to thank everyone for attending the webinar. This was a great presentation, Dr. Evans. We really appreciate your expertise and all of your experience. I think there were a couple of questions related to the EAGLE trial about the behavioral component of that, in addition to the question about the transition age youth. And I think that might actually be a more general question just about behavioral treatment. So the specific question was, in the different arms of the EAGLE trial, did they have behavioral treatment? Was it the same behavioral treatment? Was uptake the same?
Yeah.
Could that explain any part of the difference?
That's a great question. And in most studies, the behavioral intervention is minimal. So in the EAGLES trial, it was 10 minutes of individual behavioral treatment weekly for the first 12 weeks, and then bi-weekly, I think, for I mean, it was weekly so it was weekly to bi-weekly. I forget how long the weekly treatment went. I think 12 weeks. In our studies, we've gotten better abstinence rates than other groups, and I think because I work with these fantastic CBT specialists, and we do group treatment, and we just get better rates of abstinence. And I think because the patients are helping each other, we bring in a person with schizophrenia who has successfully quit smoking the week before their quit date. And they pepper that person with questions, which is fantastic. That person's got more street cred than I will ever have, for sort of what has worked. So group treatment really, I think, is fantastic. The quit line there aren't studies really published on the quit line as a behavioral intervention specifically for people with serious mental illness. Although if you talk to people at the quit line, they certainly say that they have expertise in treating all smokers, regardless of psychiatric illness.
Mm-hmm. And I think it will give the audience a chance to type in their questions in the Q&A box. But I think it's, as we've had discussions in our region around some of the major barriers to doing more of this, providing more care. Those are two of the big barriers that come up that you mentioned both of them in your presentation. One is just feeling that it would be helpful as I'm a community psychiatrist as well. It'd be helpful to have the support of behavioral treatment, which is not consistently available in all of our settings. And then the second is around the access to varenicline and some challenges. And it's really interesting to hear your experience with Massachusetts Medicaid, authorizing 52 weeks of varenicline based on research data. I'm sure there's some folks on the call who'd be really interested in knowing more about how those conversations with Medicaid went, and just, thinking about the impact from a policy perspective or a cost perspective on being able to provide this life-saving treatment.
Yep. We now have managed Medicaid programs. So still straight Massachusetts Medicaid provides 52 weeks, no strings attached of varenicline for people with schizophrenia spectrum disorders. But the managed cares are not so consistent, and Medicare, some of the managed Medicare programs in Massachusetts can have just extraordinarily high copays that are just really significant barriers.
Really thinking of intervening at that level as well. I mean, there's sort of the pharmacotherapy and the behavioral intervention, and then also the advocacy to make these treatments available. And it's an interesting time. Most of our states are somewhere in the course of Medicaid transformation. And so it is an opportunity for states and regions to really be paying attention to this and making a difference in this.
Yeah. So I think Medicaid coverage of the most effective cessation treatments remains limited in many states, despite legislation barring state Medicaid programs from excluding FDA-approved cessation medications from coverage. So there's high copays and prior authorization requirements that remain common barriers to obtaining smoking cessation medication through Medicaid and Medicare plans that ensure most smokers with schizophrenia.
So can you say that again, that there's actually federal legislation that prevents state Medicaid from excluding these treatments, but it's sort of a workaround to put these barriers in by...
Right, so they don't exclude them. but they put barriers in front of them. And so I think that's that the argument could be made that some of these barriers are effective exclusions for some people. So, if you're living on very limited income from SSI or SSDI, these high copays that can be in the hundreds of dollars are effective exclusions.
I think the other, I'm just looking to see if there are other questions that other folks have, but the one challenge that I'm sort of thinking of in my own clinical experience is the idea of accessing dual NRT, just that it's actually a challenge just for some of the people I work with to pay for NRT anyway, and then the idea of paying for two, but it sounds like the data is pretty impressive that the dual NRT is much superior to
that's right. Single. It may be equivalent. The most recent Cochrane review, and it was in JAMA a couple years ago, Kate Cahill is the first author, really postulated that dual NRT may be equivalent to varenicline. There's no head-to-head, and the Eagles trial only included the patch, no dual NRT, despite my lobbying otherwise. But one thing to do is to look and see if your state quitline provides NRT. So ours provides 8 weeks of NRT, which is not enough, but it's not nothing.
That's a good tip. That's something that we can sort of reach out to our partners on our advisory board and our other stakeholders in the region.
And although it's over the counter, Lydia, you can often write a prescription for it, and then they only have to use their usual sort of Medicaid copay.
Right.
So that's significantly less expensive.
Right. Even if you prescribe two different prescriptions. So I think it's helpful. I think it's very helpful, speaking as someone who's providing this care, to clarify what the goals should be, and then to try to address the barriers in our situations, right? To kind of think through.
Maybe it would be a nice thing if we could try to compile some of this information that's locally relevant, and provide it to folks who are on the call. It's just some practical help. I think everybody's trying to do what's right by their patients. We've presented the safety and efficacy data, but to give them some help with how to get around some of these very real practical challenges.
Yeah, no, we really appreciate the update on the recommendations and also your experience in Massachusetts, because I'm thinking that this was primarily focused on clinical providers and thinking about how each of us can improve the quality of the care that we're providing in our own settings, but that there really are issues that we could think of at a level of not just the organizational level, but at a policy level with the state departments of health, and thinking about what should they be advocating for, and what should we be asking Medicaid to pay for. And so I think compiling information, it would make sense at a number of different levels, not just the barriers for clinicians, but to kind of have some talking points and some strategies, and to learn from our tobacco policymakers who've been doing great work for, a long time trying to move this forward. So would be great partners in this. I also wanted to just provide people with some information about upcoming additional training opportunities, improving the physical health of people with serious mental illness in our Region 10 is a focus of our Northwest Mental Health Technology Transfer Center. So this webinar today by Dr. Evins is part of a webinar series. The upcoming webinar will be at the end of March with Dr. Deepa Rao, who's a wonderful psychologist in the Department of Psychiatry and Global Health, talking about stigma reduction among people with HIV and behavioral health disorders. And then also to remind everyone that one of our products last year was just launched last summer from the MHTTC is an online course that is available. It's a 3-hour course that helps support psychiatrists' kind of approach to population management of cardiovascular risk factors. So that is also available, and the link to that is on our website, and we're working on getting CME available for that. So that may be a nice opportunity for psychiatric prescribers. You can find out more about our MHTTC, about these educational opportunities and the other training and TA opportunities that we have by visiting us online at our website, following us on social media, and just emailing us at northwest@mhttcnetwork.org. You can find out information about all of these things and all of our resources. So I would just like to once again thank Dr. Evins for a fabulous presentation, and everyone for their great questions, and for attending the webinar and taking time to learn about this important topic. So we'll look forward to seeing you all in March.